Morning, dear colleagues, dear Professor Key. Thank you very much for the very kind invitation to speak. I'm very apologetic that I can only do this remote, but I hope that you will still like the contents of my presentations. The first lecture that I would like to give is on glymphatics and how they relate to shunting lesions, to AVMs, and to dural arteriovenous fistulae. There are no disclosures that are relevant to the contents of this presentation. As you've heard in the previous talks on the glymphatic system, and I have to commend Professor Key of having this really new and very exciting topic in the ANRC this year. The glymphatic system is kind of the garbage truck in the brain. It transports either through convective or diffusive flow waste products, in particular amyloid, from the periarterial into the perivenous space and therefore removes it from the brain interstitium. The way that it works is likely related to a pumping mechanism that is related to the small arteries like pulsating, whereas the venules do not pulsate. And therefore, the fluid that is present within the perivascular spaces can exit these perivascular spaces, enter the interstitium, and then is being either due convective or diffusive flow like transported towards the perivenular spaces. Now, this happens likely due to a combination of gap junctions in the surrounding the perivascular spaces or the aquaporin 4 channels in the astrocytic end feet. It is important that this flow is directional, i.e. it can only go from the arteries to the vein, and it does appear to be related, at least in part, to pulsations. Together with Professor Key, we recently published this article in the JNIS where we described this convective and diffusive flow in normal and in diseased states. In fact, in diseased states, we can have different types of problems. We can have problems on the arterial side, we can have problems in the interstitium, and we can have problems on the venous side. And this can then explain how cardiovascular and steno-occlusive disease, small vessel disease, vasospasm, subarachnoid hemorrhage, but also less common diseases such as intracranial hypo or hypertension can affect negatively the glymphatic system. I will only focus in this talk on the arteriovenous shunts, i.e. AVMs and dural AV fistulas, where the thought process is that the glymphatic system is no longer working as well because we have A, hypertension within the veins and therefore no longer an arterial to venous gradient, and B, because of the shunting flow, we will also have pulsations within the veins. And if you have pulsations in the arteries and pulsation in the veins, there's less of the convective flow happening, and therefore, in theory, less waste removal, less water removal, more congestion within the brain parenchyma. And the first time that we were thinking about this is that when we saw the following patient that I will present to you here and that we published quite some time ago in 2011. Now, this was a professional bridge player. Bridge is a very cognitively demanding game, and he used to be like in the national team at this point in Canada, and he started to lose a lot of games, and that's an excellent indication to get an MRI, of course. And on MRI, we found that the patient had a choroidal type arteriovenous malformation that did not compress the aqueduct, but still there was evidence for quite some hydrocephalus. And we said, well, maybe the patient is developing a normal pressure hydrocephalus. You see, there's a certain discrepancy between the width of the sulci and the width of the ventricles, but it definitely has nothing to do with the AVM proper, and we should not do anything for the AVM. This was a 65-year-old patient approximately, and we typically leave these unruptured AVMs alone. But the patient came back, and here are the images just like 3 weeks later. And the patient was now in full-blown dementia. Actually, he came back into the office in a shuffling gait. The wife said that he was incontinent, and he was clearly no longer himself. And we said it's very atypical that normal pressure hydrocephalus would deteriorate so fast. So we said, well, maybe there is a correlation with the brain AVM, especially since when we looked back at the angiography that we did in this patient, we saw that this AVM not only drained towards the straight sinus, but had also significant drainage into the transmedullary veins right here. And as Pierre Lajunias has taught us many years ago in patients with vein of Galen, babies with vein of Galen arteriovenous malformation, there's a certain hydrodynamic disequilibrium due to less water being like transported away from the brain due to transmedullary reflux. And so we thought maybe this is also present in this patient. So what we did in this patient was we did a partial embolization. Following embolization, you can see here the glue cast. This is before treatment. After treatment, there's no longer any transmedullary reflux. And we treated the remainder of the AVM with gamma knives subsequently. But look at now how the images changed again within the time course of only 3 weeks. This was before treatment. This was immediately after treatment. And you see that the normal pressure type findings have completely gone, and the patient's dementia reversed, and he was back again to his normal self. So, what about dural arteriovenous fistulas? If it's true for AVMs, then maybe it should also be true for dural arteriovenous fistula, because here, if you have medullary venous reflux, this may cause, again, hydrodynamic disorders, a disorder of the glymphatic system, which will lead to cognitive decline in some patients. And this was something that in 2019 we wrote up with our previous fellows, Walid and Patrick. And what we found in our series of, I think, 8 or 9 patients are the following findings, and I will go through every single case now. We have a patient, again, with a slight imaging finding of a normal pressure hydrocephalus. There's discrepancy between the width of the ventricles and the width of the sulci. We see obviously a massive cortical venous reflux, transmedullary venous reflux in this patient with a significant congestion of the veins, who presented with dementia and whose dementia following treatment was completely reversible. Another example here of a patient who has definitely like this pseudophlebitic pattern, cortical venous reflux into the transmedullary veins, who presented with cognitive decline and after treatment got better. Next case here, this was a 40-something-year-old patient who presented with cognitive decline, and he was called to have vascular leukoencephalopathy. But this is not your classical vascular leukoencephalopathy, it's not like speckled, but more confluent. And we see abnormal vessels right here. So we speculated that this patient has indeed some form of venous congestion that was then verified after angiography. You see again the significant reflux into the transmedullary veins right here. Next case, calcifications as a sign for long-standing cortical venous reflux, pseudophlebitic pattern, transmedullary reflux, and following treatment, complete reversal of the symptoms. 87-year-old with rapidly progressive dementia. Again, after treatment, the patient did very well. 75-year-old with forgetfulness, inability to care for himself, cortical venous reflux, pseudophlebitic pattern following treatment, complete amelioration, and the patient's dementia went away. This is, I think, the final case, 61-year-old patient, and it's the same story. Now, this is the final case. Normal pressure hydrocephalus type image ventricular dilatation, sulci are abnormal following treatment, complete amelioration of these findings, and also amelioration of patient's cognitive deficit. So, based on these findings, we speculated that indeed transmedullary reflux leads to cognitive decline. The rate of this cognitive impairment is likely related to the amount of cortical venous reflux, to the shunt flow, but also to the like timing of the progression, how fast it went. So, is this everything, or is this just the tip of an iceberg? Because every patient with a dural arteriovenous fistula, even if you don't have cortical venous reflux, will still have some form of venous hypertension. And this led us to actually do a prospective study where we said, okay, let's look at every patient with a dural arteriovenous fistula before treatment and after treatment and do a cognitive assessment in these patients. And the cognitive assessment is a repeatable assessment, so people do not learn from it once they've done it, and you can really check pre and post any type of intervention how their cognitive status is. So here we have a patient with a dural arteriovenous fistula, and he himself described, or his wife described, that he felt cognitively slower than previous. We do have cortical venous reflux, so we treated this patient, and he was definitely low before and normalized afterwards. But you may say, okay, this is a patient with transmedullary reflux. This patient only presented with tinnitus. There was no evidence for any form of cognitive impairment. We found this dural arteriovenous fistula. Because of the tinnitus, we decided to treat the patient. You can see that there's the facial arcade being activated here. We see that the vein of Labbé is very close to where the shunting zone is. So we treated the patient, and following treatment, his score definitely and significantly improved. He was already high functioning before, but even smarter after the treatment. And then we published this together with our previous fellows from Toronto, and could see that in each line we have like the before treatment and after treatment. Yellow means average, red means below average, green means above average. And you see that more or less every patient in every single domain of cognitive impairment got somewhat better. We are shifting here from orange to yellowish green. And this was then also found in other studies. Here, this is from the naive study from Barcelona that found that patients following treatment all and in every single domain got significantly better after treatment. So to conclude, the glymphatic system, as you've heard in this session, is a relatively newly identified system used for waste clearance. Its dysfunction may explain not only neurodegenerative diseases, but also the cognitive decline associated with NPH, with SIH, with intracranial hypertension, but also with vascular shunting lesions. And so understanding the glymphatic system may therefore open a window into new therapeutic options. With this, I would like to thank you very much for your attention. And again, thank you very much for the very kind invitation.